So I'm the speaker standing between everyone and lunch, so I'll be brief. But I want to thank Dr. Chang for his paper and presentation. I think that it's critical, as Dr. Tierney said, in this era. But I think it's important for a couple reasons, and I'll just try to put the paper in context and where we are in psychiatric neurosurgery just in a few slides. It's important for a few reasons, not only because making a lesion in the anterior limb of the internal capsule is not new, as we know. So capsulotomies have been done for psychiatric disease for decades, but obviously it's how they're being done currently that is the issue. So I think it's critical that this work comes now for two reasons. The first, I move forward with this. The first is that we've been trying for thousands of years to intervene in psychiatric disease. So we know from the fossil literature that people actually survived the procedures in the top left from the calcification and the mineralization of the trephination procedures that have been done for thousands of years in the ancient world. We know that in the medieval ages, people have tried all kinds of solutions for mental illness and psychiatric disease. Of course, not recognized at that time, but tried it in any case. And in the 20th century, we have our own history, often dark history, of different kinds of treatments that were tried, of trying to marry surgical technology and other kinds of technology with refractory mental illness, a lot of the time a reflection of the therapeutic nihilism that exists for a lot of these conditions, that in fact there are no good effective treatments for them. Everything from insulin shock comas to straitjackets to restraints. In the era of ECT, which is still obviously the gold standard for certain kinds of depression, but not without its fair share of controversy. So along the way, obviously, there have been another reason why it's important is because along the way there have been missteps, of course, and I think that's the second big reason why we ought to be starting to look at alternate ways of influencing the circuitry of mental illness. So this is Walter Freeman, who was a doctor, a medical doctor, performing an ice pick lobotomy, basically, on a patient as an outpatient procedure. So we cannot have a discussion about psychiatric neurosurgery, of course, without paying due attention to the significant mistakes and errors that have been happening in the past. So these color, by necessity, our current understanding of psychiatric neurosurgery in many ways. And we still, to this day, as functional neurosurgeons, as neurosurgeons working in this area with psychiatrists and psychologists in this area, are saddled by the legacy and the resultant stigma of the dark days of psychiatric surgery. And it really reminds us what a combination of lack of oversight, regulatory failure, lack of knowledge, and lack of technical expertise, and combining all of that with an unbridled enthusiasm can be a powerful and dangerous mix. But arguably among the most important advances in functional neurosurgery was the development of stereotaxi, and this came along in the mid to late 1940s. It's a very rudimentary arc and frame system, and what this really allowed us to do is, in a much more systematic way, develop the ability to very accurately and precisely, and in many cases safely, target regions within the brain with millimeter accuracy. So it's really the development of stereotaxi that underscores 3 points of discussion that I'll make in this talk. The first, that psychiatric disease has driven, in many ways, neurosurgical innovation. It maybe hasn't been the primary driver, but it's absolutely one of the major pillars that have driven neurosurgical innovation. And you see that in 3 of arguably the most influential or talked about forms of surgical technology that have come out. Focused ultrasound, and it didn't come out very clearly, but the top was one of the first suggested uses of focused ultrasound in a lobotomy, actually, in the 1950s. And then we see deep brain stimulation and gamma knife radiosurgery. So really the need and the strong push to develop novel, effective, safe, less invasive approaches to psychiatric disease has driven a lot of interest in neurosurgery. And the second thing is that we are now in 2016 really in a critical time in the history of neuromodulation for psychiatry, not least of which because several of those treatments that I just mentioned are now experiencing a level of scrutiny. So we know recently, last year, the interim analysis of the Broaden study, which is a major multi-center study looking at deep brain stimulation in major depression, failed essentially, the interim analysis, showing no significant difference between sham and active stimulation. We also know that due to a recalculation and recalibration of some of the data, that even the gamma knife capsulotomy literature has now come under some scrutiny as well. So a lot of the accepted dogmas, a lot of the enthusiasm that we saw for a lot of these technologies is now being tempered by the realization that maybe we ought to look at things a little more systematically and dig deep rather than broadly. So if you take these 2 points together, the third point is that the next steps really will determine the viability of the field. And it's important to realize that we are now at this juncture know more about the brain and about these conditions than we ever have at any point in human history. We now have the most sophisticated tools we've ever had at any point in human history, and it's basically our obligation to see whether in fact the next steps, certainly in our field, will determine the viability of effective neuromodulation strategies for psychiatry. So how can focused ultrasound help? I think there are primarily three ways. The first is certainly in the context of high-resolution imaging and with clear and well-defined outcome measures, is to re-examine, as Dr. Chang has started to do, certainly whether lesions still have a role in refractory psychiatric disease. So new targets, perhaps not practical without image guidance, need to be reevaluated. Their effect on brain circuitry need to be examined in real time, and combining focused ultrasound with maybe other more sophisticated tractography measures, resting state fMRI, metabolic imaging will help reinvent really the world of lesions in psychiatry. We touched upon this in the movement disorder panel, whether we have the ability to modulate the brain and certain nodes within, for example, the affective or anxiety circuitry, whether we can do that in a non-invasive and perhaps even non-permanent way. So unlike the movement disorder literature, the DBS literature for psychiatry is less established. It's less of a goal. It's certainly not a gold standard as DBS is, for example, in Parkinson's disease in some patients. So that hill and that bar that needs to be met is not as high. So here we have the ability to really look at whether neuromodulation and stimulation technology can really make a significant difference. And finally, can we look at low-frequency applications to potentially enhance things like neurogenesis in patients with refractory depression, where we know hippocampal volumes are affected with chronic illness? Can we enhance the delivery of BDNF and other growth factors to the brain, where we know that doing that can significantly, and certainly in preclinical models, help with depression? So certainly thinking outside the box, I think that this area has quite a bright future in psychiatry, and will be examined further. And just as a quick just illustration of where the field is headed in many respects. This is a PubMed search, basically, of the number of publications dealing with focused ultrasound in the brain. Basically, it's a quick and dirty analysis, but it shows you that the future is quite bright for focused ultrasound in the brain. So this is the number of publications per year since the 1940s. So certainly that slope will probably be near the ceiling, I think, at the next time that there's a symposium. So again, the study that you saw and heard today by Dr. Chang, I think, is of historic and of significance. I think that it's the latest in the long line of novel surgical approaches to psychiatric illness. I congratulate Dr. Chang and his team for moving forward with this, and I'm very excited at the next steps of what's to come in the future. Any questions? Happy to answer them.